It's January 2025. The New York Times runs a headline, "Study links high fluoride exposure to lower IQ in children." Within 48 hours, the inboxes of pediatricians all across the US are full of parents asking whether they should be switching away from fluoride toothpaste for their children, should they be switching to bottled water, and should they stop letting the dentist anywhere near them. I get that. That headline is terrifying. It is also not quite what the underlying paper actually says. G'day team, welcome back to Overheard in the Emergency Room. I'm Dr. Cois, emergency physician, evidence nerd, and your guide through this messy, fascinating world of medicine. This is Overheard Journal Club, episode 2. We'll apply our PICO framework to go through that paper. We'll get to what's good, what's not, and what actually to do with it. Whether you're a clinician, a med student, or a parent who got handed a panic headline by an algorithm. Today, Taylor and colleagues, JAMA Pediatrics, January 2025. Fluoride exposure and children's IQ scores, a systematic review. 74 studies, 20,000 kids, real data, real signal, and a real story about how that signal got weaponized the moment it left the journal. Hit like, subscribe, and the notification bell. And go to drcois.com for the full companion blog post and reference list. Let's go. Here are 2 things you need to hold in your head at once. Thing 1. Community water fluoridation has been a cornerstone of US dental public health since the 1940s. The target in fluoridated municipalities is 0.7 milligrams per litre. The World Health Organization upper limit guideline is 1.5. The EPA enforceable cap is 4. At the right dose, fluoride dramatically reduces dental caries, and that benefit is unambiguous. Thing 2. Over the last 15 years, a body of literature, mostly from regions within very high naturally occurring groundwater fluoride, has suggested that at high exposures, fluoride may affect neurodevelopment. The 2024 NTP monograph concluded with moderate confidence that higher fluoride exposure is associated with lower IQ in children. Taylor 2025 is the formal meta-analytic synthesis of that literature. And the story doesn't stop at the abstract. The same week as the paper landed, Robert F. Kennedy was confirmed as the Secretary of Health and Human Services. Children's Health Defense, the organization he founded, has campaigned against community water fluoridation for years. Suddenly, this paper was being held up as definitive proof that fluoride is poisoning American children. So we owe it a careful read, not just panicked, not dismissive. Now, let's run through this PICO style, with the caveat that this is a meta-analysis of observational studies, so intervention really means exposure. First up, the population. They included 74 studies, 64 were cross-sectional and 10 were prospective cohort. They included roughly 21,000 children, and the geography matters. 45 of 74 studies were conducted in China, 12 in India, 4 each in Iran and Mexico, a handful in Canada, Pakistan, Denmark, Taiwan, Spain, and New Zealand. 0 in the United States. Now just remember that. The exposure was measured in 3 ways: group level fluoride in drinking water, group level urinary fluoride, and individual level urinary fluoride. Drinking water concentrations ranged from under 1.5 milligrams per litre to well above 4, from US fluoridated city levels, 1.5, up to endemic fluorosis regions of rural China. The comparator, lower exposure groups within the same study. That's a village at 3 milligrams per litre compared to another village down the road at 0.5. And the outcome was children's IQ, which was measured with a grab bag of instruments. Variability in the outcome measure will matter when we get to the appraisal. So when it comes to the result, there are 3 analyses to focus on. 1, the mean effects meta-analysis. In plain English, kids in higher fluoride groups had statistically significantly lower IQ than kids in lower fluoride groups, and the effect was meaningful. But, and this is critical, 52 of those studies included for this portion of the analysis were studies that had a high risk of bias. When restricted to just the 12 low risk of bias studies, the effect shrank. It was still significant, but less than half of the effect. 2, the dose response analysis for drinking water. 31 studies were stratified by exposure. Below 4 milligrams per litre showed an inverse relationship. Higher the fluoride concentration, lower the IQ, and it was significant. Below 2 milligrams per litre, the relationship showed the same direction, but it lost significance. Below 1.5 milligrams per litre in the pool analysis, there was no difference in IQ. That last point is the one the panic headlines never mention. In the full pool drinking water analysis, the association with IQ disappeared at or below the World Health Organization's upper guideline. So there is a real signal at high exposures, ambiguous and underpowered at the WHO threshold, and essentially no signal at the 0.7 milligram per litre target that an American fluoridated tap delivers. 3. The individual level regression slope analysis. Here, they looked at 13 studies of around 4,500 kids and their individual level urinary fluoride levels. The headline is that a 1 milligram per litre increase in urinary fluoride was associated with a 1.63 lower IQ. But in the lower risk of bias subset, the IQ was lower by only 1.14 points. So what does that mean? For an individual child, nothing you would ever notice. Would you as a parent be able to tell two kids apart with an IQ of 102 or 109? I don't think so. But even so, at a population of 300 million people, a 1 or 2 point downward shift in the mean of a bell curve translates to thousands more children falling into the intellectual disability tail. That's the public health argument, and it's legitimate. And if it applies to the population being shifted. So just two very big ifs. So what's good and what's not? This is the part of Journal Club where you stop being a fanboy and start being a critic. So what's good? One is the scale. It included 74 studies, 2,100 kids, multiple countries, and multiple instruments. The largest and best organized synthesis we have on this question. 2, the rigor of the paper. They published the analytic protocol ahead of time, assessed risk of bias, performed their analyses in a stratified manner, and made every extracted data point publicly downloadable. This really is the gold standard for transparency. 3, the signal persisted across subgroups, regardless of sex, age, country, instrument used, or exposure timing. When a signal holds up under that much stratification, it's harder to just wave it away as confounding. 4, the individual level urinary fluoride analyses are biologically the most informative subset. They measure what a child actually absorbed, not what was in the village water main, and they're dominated by low risk of bias prospective cohort studies. That's the strongest evidence in this paper. But what's not so good? And a quick pre-bunk before I list these. The influence tactic to watch for in the public conversation around this paper is cherry picking. That's amplifying the parts that fit a preferred conclusion and ignoring the parts that don't. Once you hear it, you'll see it everywhere. 1. Where the papers that were meta-analyzed actually came from in the world. 45 of 74 studies were conducted in China. There were 0 in the US. Most high exposure studies come from regions with naturally occurring groundwater fluoride levels 2 to 10 times higher than what an American on a community water supply ever encounters. So if you're trying to apply the findings of this study, you're extrapolating data from a rural endemic fluorosis region in rural China to a suburban area of the United States. 2. Risk of bias. 70% of included studies were rated high risk of bias. The full pooled effect is being heavily pulled by those weaker studies. When you restrict to only low risk of bias studies, the effect halves. 3. Biomarker noise and heterogeneity. An editorial in the same JAMA Pediatrics issue by Levy argued that urinary fluoride is a noisy biomarker and that the studies aren't really measuring the same thing, the same way, and you should be cautious about a single pooled number summarizing them all. 4. Co-exposures. Many high fluoride regions also have higher arsenic exposure and iodine deficiency, as well as heavy metals from coal burning. You cannot fully untangle fluoride from everything that travels with it in endemic regions. 5, and this is the one that doesn't get said often enough. The authors themselves in the discussion are explicit. This meta-analysis was not designed to address the broader public health implications of water fluoridation in the United States. That's the authors, not the ADA, not me, the authors. Now let's look at a head-to-head example with more US relevant evidence. Do we have better data from a population that's genuinely comparable to the US? Well, Doe and colleagues in 2024-25 conducted a population-based study using Australia's National Child Oral Health Study. They followed kids exposed to community water fluoridation at 0.6 to 1.1 milligrams per litre, the range an American kid actually experiences, and used dental fluorosis as the biomarker, and assessed cognition using the WAIS-4. What they did find is that there was no association between early life fluoride at community fluoridation levels and cognitive neurodevelopment. A 2023 meta-analysis by Veneri shows the same direction in low risk of bias studies. No clear effect at exposure levels expected in the US communities. So this meta-analysis by Taylor is a high-quality synthesis of a body of evidence that is genuinely concerning at high fluoride exposures and generally uncertain at low ones. It is not a paper about American water fluoridation. Anyone telling you it is likely using this data to justify something that the paper simply doesn't support. So how should this modify your practice? This is Journal Club, so this section is for the clinicians. Don't throw the fluoride out with the bathwater. Headlines can be loud. The signal at community fluoridation levels is not concerning at all. The dental caries benefit at those same levels is well established. For the patient drinking from a US municipal supply at 0.7 milligrams per litre, the risk-benefit math still favours fluoridation. 2. The signal is real at high exposures, so screen for them. Ask patients on private wells in regions with high natural groundwater fluoride, that's parts of southwestern US, the southern plains, certain pockets of the Carolinas, whether their well has been tested. The US Geological Survey estimates more than 2.9 million Americans get their drinking water from sources above 1.5 milligrams per litre, and around 170,000 above 4 milligrams per litre. Those families deserve a conversation about testing and, if needed, point of use filtration. 3. For pregnant patients and bottle-fed infants in high fluoride regions, the CDC already recommends an alternate water source if the supply exceeds 2 milligrams per litre. That recommendation was made for dental fluorosis, but it incidentally addresses any neurodevelopmental signal we're worried about. 4. When patients ask, should I stop using fluoridated toothpaste? The answer is no. Topical fluoride from toothpaste accounts for a tiny fraction of systemic exposure, and the evidence for cavity protection is unambiguous. The reflex to throw away the toothpaste is cherry-picking in real time by grabbing a hold of the IQ headline and ignoring the dental disease numbers. 5. Stay calm in front of the patient. The most useful thing you can do right now is to be unhurried and evidence literate. You don't need to be defensive about fluoride, and you don't need to dismiss the IQ paper. You need to be able to say, yes, that paper is real. Here is what it shows and what it doesn't. And here is what we know about your water and your kid. So here are my 3 takeaways from this episode. 1. Taylor 2025 found a real inverse association between fluoride exposure and children's IQ in pooled global data, driven mostly by high exposure, high risk of bias studies with a relationship that was largely absent below 1.5 milligrams per litre of drinking water in the full pooled analysis. The effect in the best quality individual level data is around 1 IQ point per 1 milligram per litre of urinary fluoride. 2. The paper does not address community water fluoridation in the United States, where the target is 0.7 milligrams per litre. The authors say so explicitly. Anyone using this paper to argue for taking fluoride out of the US municipal water supply is cherry picking. 3. Identify your high exposure patients, private wells, high fluoride regions, pregnancy and infancy, and intervene there if appropriate. Leave the toothpaste alone. If you got value from this episode, like, subscribe, hit the notification bell. Drop a comment with the next paper you want me to break down. Listener questions, jump the queue. Share this with a parent, resident, or colleague in your life who got handed the panic headline and is still trying to figure out what to do with it. As always, the companion blog, full reference list, and the original paper are over at drcois.com. I'm Dr. Cois. Let's keep chasing less bad days and more good decades together. See you next time, and hopefully not in my emergency department.